Our next speaker is Dr. Pascual Sánchez Juan. He's a neurologist at the Hospital University Marqués de Valdecilla in Santander. He's an expert on prion diseases and dementia, particularly in Alzheimer's disease and behavioral neurology. He's a clinician and a PI, so an investigator of the Dementia Research Group, and of course Cibernet, and a member of the Executive Committee of the Dementia Genetic Spanish Consortium. Now, he's going to talk today about imaging of the brain amyloid in real life. So thank you very much, Pascual, for coming.
Thanks a lot for the invitation. I'm going to start about amyloid imaging in real life, and I thought that it was the best thing to start is with a patient. It's a patient that I saw in the last century while I was still resident. It's a gentleman of 67-year-old that complained of memory problems. Also, the mood has changed, and the symptoms have increased in the last years. But otherwise, he's perfectly functional, and the neurological examination was unremarkable. The mini-mental was 27. He failed the 3 recall items, and the CT scan and the lab tests were absolutely normal. At that time, I made the diagnosis of memory complaints associated to aging, no evidence of Alzheimer's disease. At that time, in the Mayo Clinic, they started following up patients like mine. They called them mild cognitive impairment. They realized that 10 to 15 of these patients will develop Alzheimer's disease in 1 year. If they follow them up for 3 years, even 50% of them will develop Alzheimer's disease. However, not all of them will progress to Alzheimer's disease. Around 30% will remain stable. And the thing is, it was very hard to distinguish the one that will progress than the one that not. For that, we need biomarkers. And in 2004 was the arrival of PET. That was the first amyloid radio tracers. This was a huge step forward that allowed to visualize in life, in patients like mine, amyloid plaques. Sorry. It's not working. Yeah. No, it's not working. Yeah. Here you can see in the cortex and the striatum. The neuropathological study shows that PIV has affinity to fibrillar amyloid plaques. That's the main target, and also to less degree to diffuse plaques, and also the amyloid to the vessels. But it has no affinity to tau or other beta-sheet structure proteins like alpha-synuclein. From a diagnostic point of view, amyloid scans is very good test to detect moderate to frequent neuritic plaques scored with the SERAD criteria. And that would mean that a positive amyloid scan is equivalent to intermediate to high Alzheimer's disease pathological changes. I'm not going to focus on the contribution of amyloid PET in research. It's huge. Most of you are aware of that. But I would just like to mention a very practical one in clinical trials. It has really changed clinical trials in Alzheimer's disease. Amyloid PET sub-studies in bapineuzumab and solanezumab clinical trials showed that from 10 to 13% of ApoE4 negative patients were negative for amyloid PET. They were treating people with anti-amyloid drugs that have no amyloid in the brain. And of course, this has made that now all clinical trials is compulsory a selection based on amyloid, and all patients have to perform CSF analysis or amyloid PET analysis. And another very key element is the use of this test in target engagement. As you can see here in this crenezumab study, 3 patients with sequential with sequential amyloid scans that show how the amyloid load is decreasing with time. But I'm going to focus on the use of amyloid PET in clinical practice, how this is translating to the patient. What scientific evidence do we have to use this test in the patients? Well, as you know, PIV is, thank you, the clinical use of PIV is very limited because of the half-life is very short, 20 minutes. So in practical, you cannot use it in a clinical practice. But since 2012, we have 3 compounds that have been approved for clinical use. And these compounds are available in many hospitals in Spain and in different countries. But the clinicians are confused about when to use it, in which scenarios to use these tests, which, as we have seen, are very powerful to detect amyloid plaques. So I think to myself, these are the 3 questions that as a clinician I would like to answer before starting to use this test with my patient. Is it really clinically useful? I mean, does it help the management of the patient to me and the patient? If this is the case, which patient should we scan? And in which clinical scenarios should we scan? And does it help me, in addition to diagnosis, to assess the prognosis or disease severity of the patient? That will be the main 3 questions, and my talk will try to give some evidence, scientific evidence for these 3 questions. So starting with the first one, the quick answer is the clinical utility is not clearly established, but we are almost there. And in 2013, a medical panel concluded that there was not enough evidence to fund fluorbetatol, which was the first fluoride compound that was approved. And since then, several studies have attempted to quantify the added clinical value of this test, especially in change of diagnosis, of treatment, how we modify how we treat the patients. And, but there are not that many studies. A very recent meta-analysis this year, including only 12 studies and like 1,000 patients, they concluded that change after PET happening in 1/3 of patients, more or less. But you have to really be careful when you analyze these studies, because the clinical utility of this test is very context dependent. It depends on the patients that you scan and the neurologists that do the evaluation. And most of the studies that have been done, they are for the first adopter of the technique. So they are highly technological centers, they are tertiary centers. So they may not be representative of the whole of the real world of clinical neurology. I had the rare opportunity to perform 2 studies, one in a tertiary center in UCSF in San Francisco, analyzing the clinical utility of this test, and another in Santander, in Valdecilla. And I had the opportunity to compare between these 2 centers the utility of this test. And we showed that paradoxically these tests are much more valuable in secondary centers like in Valdecilla than in tertiary centers like in UCSF. With double, the ratio of diagnostic change was double in Santander compared to UCSF. So definitely more data is needed. We need more data with more patients, different neurologists, different centers, different patients, and more data is coming. There's a big NIH-funded study called IDEAS, led by Gil Rabinovici, which has been scanning nearly 18,000 patients. They focus on MCI and on atypical dementia. And the preliminary results have been disclosed in the Chicago meeting, and they found that around 2/3 of the patients presented changes after amyloid PET. So I think it's quite compelling. There is another study in Europe, but they just started recruitment. Sorry. So I think it's safe to assume that these tests are helpful in clinical practice. But then, in which patient should we test? Shall we test asymptomatic patients? In 2013, there was a panel by the American Academy of Nuclear Medicine to try to write some guidelines about the rational use criteria of this test. And they concluded that it was not recommended to test asymptomatic patients. The biggest meta-analysis that have been performed studying the prevalence of amyloid in asymptomatic patients, published in 2015 by Janssen and colleagues, showed that the prevalence of amyloid in asymptomatic people is age-dependent. The older you are, the more probability you have. And as an average, people older than 65 have 30% prevalence, 30% probability to have an amyloid PET positive, which complicates the interpretation of the result of the test. So there is a lot of uncertainty about the meaning of this finding in asymptomatic people, so therefore it's not recommended to test asymptomatic people in clinical practice. So what about subjective cognitive decline? This is an interesting phenotype, a hot phenotype right now. This phenotype means people that has memory complaints, but when you do neuropsychological tests, they are completely normal. So the rational use criteria, they do not recommend to test these people. And this is in line with the International Working Group definition by Dubois and colleagues, that they claim that SCD is not a proxy of preclinical Alzheimer's disease. So you should treat them as asymptomatic. And this is in concordance with the Jensen meta-analysis that shows that the prevalence of SCD, amyloid in SCD is the same as in asymptomatic people. So the recommendation so far, even though this is a field that is in expansion and the phenotype of SCD is being defined, but so far it's not recommended to test SCD in clinical practice. And finally, mild cognitive impairment. The same as my patient. What should we do with mild cognitive impairment? Well, the rational use criteria, they recommend to test patients with MCI, persistent or progressive, and of an unexplained cause. And this is also in agreement with groupal comparison. When we compare people with MCI with amyloid PET, they are more often converting to Alzheimer's disease in the future. In a groupal way. And this is also in line with the International Working Group criteria. Well, they accept that Alzheimer's disease, you could diagnose Alzheimer's disease with an MCI syndrome plus a positive amyloid PET alone. But when you, from an individual perspective, that's what matters for us as a clinician, I have the patient in front of me and I have to tell her if the positive test, when is he going to develop the disease and how is going to be the course. And I have to say that the level of evidence is still low. There are 4 Cochrane reviews that found not enough evidence that these tests are useful in MCI to predict Alzheimer's disease. And the guidelines of the American Academy for MCI by Peterson last year, they do not recommend to test in MCI. In any case, if you test, you have to take into account that, as we said before, these tests are so dependent of age and ApoE, and you have to take into account this context, age and ApoE, because it's going to give you the prior probability to have a positive test, and you have to take this into account. Definitely more data is needed, and IDEAS is going to supply a lot of data because they are testing thousands of people with MCI, and so that will be very useful. Our experience in Valdecilla after scanning more than 100 patients with amyloid PET is that MCI is a diagnostic category where amyloid PET is very useful. It really have add clinical value, and we perform a model to detect, to predict which are the factors that are influencing diagnostic in change. MCI is positively correlated to a diagnostic change. So in our experience, it's also in favor of the guidelines. And finally, dementia patients. Should we treat dementia patients? Should we scan dementia patients? Well, the rational use criteria do not recommend classical Alzheimer's disease because it doesn't add information. And they recommend only in these 2 subtypes, atypical dementia and early onset, less than 65. Because in these subtypes, the differential diagnostic is much wider, so the test can add more information. This is also our data. Our study in San Francisco, what we did is to analyze the discordance between the diagnosis of the clinical and the result of the test, and we saw that the bigger the discordance was, the more added value give the test to the different subtypes. And we saw that for atypical forms of dementia like corticobasal syndrome or frontal Alzheimer's disease, which are rare forms of dementia, in these subtypes, the tests give more added value. And we replicate this finding in our study in Valdecilla, where for rare dementia where more added value was found. Like, for example, in primary progressive aphasia and corticobasal syndrome also. Oops. And just to give you an example, this is a patient that we saw in our clinic. It's a man that started with a logopenic aphasia, and classical logopenic aphasia. Actually, we published this with Marilu Gornotempini, who is the one that described this syndrome, that is classically associated to Alzheimer's disease. But when we performed an amyloid PET, it was negative, and we found that there was a very strategic stroke in the superior temporal gyrus. This is another example from our clinic. It's to give you an idea of how it's useful in young dementia cases. It's a 29-year-old lady with a rapidly progressive dementia. We screened for CJD and for autoimmune encephalitis, and it was negative. Someone, it was not me, decided to do a PET-PIP, and it was positive. And the patient ended up having a rare presenilin mutation. Very, very aggressive case. And finally, question 3. In addition to diagnosis, does it help us to assess prognosis or the disease course? Well, again, the quick answer is no. The correlation between amyloid PET and cognitive score is weak in dementia, and the PIP becomes positive before cognitive age with a wide range. So a symptomatic patient with a positive PIF, we cannot tell if we develop the disease in 4 years, in 10 years, or won't develop the disease. So it's not really helpful. And predictive models in prospective course, when you enter in the model A beta, tau, and hippocampal volume, A beta do not make an independent contribution. But I think there are 2 recent developments that are at least worth mentioning, that are interesting. One is a proposal made very recently by the Harvard group, by Keith Johnson, and what they propose is to do an amyloid in vivo staging. So what they propose is to use the involvement of the striatal as an analogy of the TAL neuropathological criteria to do an staging. So it would be a stage 0 person that has no amyloid in the cortex and no amyloid in the striatum. A stage 1 when you have only amyloid in the cortex, and stage 3 would be the most advanced patients when you have both in the cortex and in the striatum. So in that way, they allow them to make a better prediction for hippocampal volume and cognition. So this data have to be replicated, but I think it's interesting because it's easy to incorporate this to the clinic. And finally, the dynamic measurements of A beta. In the recent years, there have been several editorials in neurology advocating for taking into account the rate of progression of accumulation of A beta, not only to have a positive or negative amyloid PET, but how rapidly we are accumulating the amyloid. And probably the most compelling evidence for this approach is very recent and come from the same lab, from Bill Jagos in Berkeley. What they have done using ADNI population is to study people that in ADNI are negative for amyloid PET, and they are cognitively normal. These people have been sequentially scanned, and they are being followed up for 4 years. And what they found is that 60% of them are A beta accumulators, so the A beta is increasing with time, and 40% remain stable. Again, these are people with negative PIP at the baseline. And the interesting thing is that the accumulation rate was associated to memory loss, again in people that are negative for amyloid PET. And very interestingly, the same group showed that these A beta accumulators also were related to higher tau levels. In a subgroup of patients, they also performed tau PET, and they saw that the levels of tau increased with the degree of PIP accumulation. So as a summary of my recommendation for clinicians, taking into account the scientific evidence is still scarce for the use of this test. I think that up to date is not recommended in asymptomatic or SCD. In clinical practice, a different thing is scientific research cohort, but in clinical practice is not recommended. In MCI, I would be more restrictive than the current guidelines, and I will focus on young person. At least in our centers, we only test people that are younger than 70. and especially in case with comorbidity or special situations, like if you want to shunt a patient with hydrocephalus, or in these situations, that's when we use the test. And definitely I will include more markers and the context, the age and the genetics. In dementia patient, I think it's clear we go with the recommendation, young and atypical, and I think that's the target. And I think there is not enough evidence today for to follow disease severity. But I will follow these two new developments, amyloid in vivo staging and accumulation rate, at least from the conceptual point of view. I think they are very interesting. And finally, as a take-home message, I think that amyloid PET scans are very sensitive, are a great test to detect moderate to frequent neuritic plaques. But of course, this is only one facet of brain aging. We are only looking at one aspect. And this is not equivalent to Alzheimer's disease diagnosis. I think that's a clear message for clinicians. And due to the complexity of this phenomenon, in order to estimate individual risk with higher precision, that's what we want as clinicians, we definitely need to improve our knowledge in context, the age, cognitive reserve, comorbidity, genetics, and incorporate different markers capturing the main actors of neurodegeneration, like the ATN classification, for example, that has been proposed in the recent criteria. And that was, sorry, all. Oops. I think it's, the acknowledgement slide is missing. Okay, I want to acknowledge my group, of course, and my collaboration, the Nuclear Medicine Group and the Memory and Aging Center in UCSF, especially Gil Rabinovich and Bruce Miller. Thanks a lot.
Okay, thank you very much for your important recommendations. Any question has to be really fast.
Just a curiosity, is there any, what do you think is the reason why the rapid accumulators have something to do between that biomarker and tau? Do you think is there?
I think there is a causal relation, and the accumulation of A-beta is probably promoting that tau levels are increasing and tau are going out of the hippocampus and the middle temporal lobe. I think this is. I think we have. I mean, from cohort studies with tau PET and amyloid PET, we see this pattern that. When you have amyloid and tau, is when tau goes out of the temporal lobes, and this is correlated with clinical symptoms. I think there's a causal correlation with that.
Thank you, Pascual, for your excellent lecture. According to your data, do you think we need to change our perception about the PET scans in clinical trials, yeah, and the role of this PET scan to select patients and to monitorize the evolution of patients under trials?
Yeah, I think we clinicians need to think how we change. I mean, normally I hear that a false positive it's a positive scan with something that is asymptomatic. To me, this is not a false positive, because this is a true positive, because probably these people have neuritic plaques in the brain. The clinical meaning of that, we really don't know. We need more information, we need the context, so we need to refine how we manage the diagnostic procedure. But definitely this have to be changed, because most clinicians do not get this concept that what we are looking at is a neuropathological thing, that's the plaques. But plaques doesn't mean that you will have an Alzheimer's disease in 4 or 10 years. So we need more information to get to that.